My name is Thomas Patrick Loughran Jr. I'm a professor of medicine and the director of the Penn State Hershey Cancer Institute. It's a very important message for the people in our state to realize that most cancers, even the ones that people fear most, like lung cancer, for example, it's highly curable if it's detected very early. So generally, solid tumors, which are the more common cancers, we classify from stage 1, 2, 3, and 4. Stage 1 being the earliest, stage 4 the latest. And, as a broad message, if someone is diagnosed with a stage 1 cancer, the treatment is surgery, and usually the surgery is very effective in curing patients.
Hello, I'm Dr. Randall Oyer, Medical Director of the Cancer Programs at Lancaster General Hospital. We know that cancer cells are growing without control in the body. And at first, the only tools we had to change that were surgery, radiation, and chemotherapy.
Standard chemotherapy has been around for a while, probably starting in the early 60s for some types of cancer. What we've done best over the past several years is really manage the toxicities and side effects of that treatment with newer medications that make it more comfortable for our patients getting such toxic chemicals. What the field is moving towards, and there is already certain specific examples, is that at the time of the diagnosis of cancer, we look at your DNA, not the DNA of the tumor, but we look at the DNA that you've inherited from your mom and your dad, and we can predict what's the best drug to use and which drug is going to work, but also the best dose to use, so that we can really model the therapy for the patient with the standard drugs.
Radiation can entirely wipe out a cell population in high dose and can cause damage to normal tissue, but sometimes it's the most effective and least toxic way of wiping out cancer.
I'm Roland Alexander, medical oncologist, Harrisburg, Pennsylvania. There are other treatments that we have come to use in treating cancer that are not chemotherapy. And two examples of treatments that we give that are like that are agents called targeted agents. And these are agents that are derived from an understanding of the biology of normal cells. And what we're doing with these agents is we're interfering with the mechanism of cells interacting with their environment. So that by interfering with these different pathways, we call them, different sequences of chemistry that occur within the cell, we can have a disproportionate effect on the cancer cells. And less of an effect, although it's not without effect on normal cells, but less of an effect. And the third group of treatments we use are monoclonal antibodies. And these are treatments where we have an antibody is something that your body makes in response to an infection, for example. We can make an antibody to particular features that we commonly find on some cancers. And that allows us to have more of a targeted, kind of a smart missile effect on those tumors. We have monoclonal antibodies that are effective in breast cancer, for example, and lymphoma. We're developing them in some other diseases as well. And in that situation, we can have a far greater impact on the cancer than we do on the host, on the normal healthy cells.